Hello everyone, I'm Sang-Chul Lim. I'm very happy to join this Dentium live and follow-up session at every month. As always, today's live surgery will be performed by Dr. Chung. The topic for today is immediate implantation in a narrow ridge. Through today's surgery, you will be able to learn how to manage lower anterior area, which is periodontally compromised situation. Let's take a look at today's case. A 73 years old female patient was prepared for surgery. Her chief complaint was my lower front tooth is broken. Past dental history, actually almost done by implant surgery, except lower anterior area. Past medical history, hypertension, arrhythmia, and the surgeries was done 10 years ago. And about this cone-beam CT view shown us about this narrow anterior ridge, actually about 4 millimeter from 42 area to 32 area. So really narrow ridge. It is a tough situation to have an implant installation. Intraoral view is here. 3 anterior teeth was movable due to periodontally compromised situation and gingival swelling and mobility and also the pulse discharge. And another one, the lateral incisor, left lower lateral incisor was broken. So tooth will be extracted and immediate implantation using bright tissue level, diameter 2.0 diameter. Length will be 11 millimeter. Bone grafting using osteogenocollagen and collagen graft 2. Today's surgery point is here, is bone grafting and using the bright tissue level. The always is bone grafting combined with bright tissue level is better than the ever done by bone level implant fixture. Cause of this bright tissue level is unique shape and the gross anatomy. Actually, it is a super simple invention to have a simpler implantation concept. Narrow implant, narrow diameter, however stronger than the same diameter as bone level implant. So basically, this bright tissue level implant have external connection. Beveled external connection is unique and unique characteristic. 20-degree external beveled external connection is the characteristic, and the big differences between another tissue level implant system. Actually, as you know, the Straumann style implant fixture, the tissue level is internal connection, even though the tissue level, however, internal connection. So have some limitation, the squeezing, the diameter of fixture. However, this bright tissue level is external connection. So we can squeezing the diameter for the 2.0, 2.5 is acceptable and possible to make a good result for narrow ridge. So concave neck and also 1.5 diameter, 1.5 millimeter neck portion and dome-shaped body. It means a very strong point because of this dome-shaped body gave us a higher insertion strength during implantation. Because of this, the dome-shaped body engaged marrow space, actually not the cortical surfaces, and also extremely reduce the top portion of the ridge crest. The single platform, 3.8 millimeter diameter. About osteogenocollagen, it is very versatile, and the good news is bone graft materials easy handling of a collagenized bone graft. It means actually collagen binder holding particulated this bone graft material. So easy handle, easy molding, and get the better the stability. So as you know, that during the GBR procedure, bone forming procedure, bone formation procedure, during this procedure, you know, mobility is worst situation. So stability is most important thing to make a new bone formation, right? So this graft materials helping the stabilized bone grafting materials to the defected area. So this osteogenocollagen helping the better bone forming situation. Okay, another one interesting regenerative materials, collagen graft 2. This collagen graft 2 introduced by Dentium company also. It is collagen matrix, thick collagen matrix. So different to collagen membrane, the barrier membrane. So this collagen graft 2 is working as the soft tissue friendly, the healing, helping healing situation, right? So we can use these collagen graft 2 materials on ridge preservation or the ARP and also the GBR procedure and the contour augmentation. There are many usages for this collagen graft 2, and also this collagen graft 2 is porcine tendon derived thigh bone collagen. It means actually optimal collagen degradation timing and the ratio when you use this collagen graft 2 into the defect. You know, the collagen materials, for example, the longer sustaining this defected area with grafted materials, so it is not available to have new bone formation because of it is not able to have empty space to make a new bone formation by bone cells, right? So early resorptive of this collagen binder, it means so faster collagen binder means softer the physical the properties, so difficult to handle, difficult to molding, so lesser than normal situation to have stable the stability when we have a bone grafting materials applied on the defected area. So this optimal degradation of collagen binder is very important factor to have a choice, to have a choosing this the regenerative materials, something like the collagenated bone graft materials and collagenated regenerative materials. Okay, let's move to similar case. This similar case shown you to understanding the comprehensive understanding about the narrow implantation with easy bone graft here. Number the 11 areas are already done by root canal treatment. However, the bone defect, angular bone defect was seen the mesial and distal part of this root. So extraction, and after healing, we're going to do the implantation on this site. The actually delayed approach situation. So when we have this implantation, we can use pin guide system. Pin guide system is unique invention for the flapless surgery. Actually, when we have a flapless surgery, the first thing to have difficult to solve is bone morphology, right? So a flap open case, flap open surgery case, after flap open, flap reflection, we're going to see full screening the underneath soft tissue areas, bone morphologies. So defect or some concavities or some the bone qualities we may know all about this situation. However, flapless surgery case, actually it is very difficult to recognize bone qualities and bone shape and morphologies, even though the bone defect. So this pin guide helping the bone morphology, to recognize bone morphology underneath soft tissue area. First, pin guide blade marker and pin insertion between bone surface and the periodon, the periosteum. So this pin guide get the stability between this bone surface and the periosteum, and also this pin guide gave us an information about these areas, bone geometry, some concavities, including all the geometry around this area. So in this case, actually, after insertion of the pin, Dr. Chung gets some incision on the labial portion. Why? During this pin insertion procedure, he recognized some of defect on labial side. So he decided to incision and flap reflection. So as you know, as you can see, labial portion, some of the bone dehiscence and bone defects are shown. So after the insertion of the parallel pin and after insertion of implant fixture, you may do something more. What? Bone grafting, right? So after insertion of a bright TL system, diameter 3.0, 11 millimeter, and we made something to do on this, the labial bone defect, the bone grafting and the covering. So about bone grafting, we use this osteogenocollagen as a bone grafting material. So this osteogenocollagen, the genograft materials, collagenated bone, they gave us both of graft materials and collagen bone the advantages. First one, genograft gave us a better bone forming situation compared to alloplastic material, right? And second, the collagenated bone gave us easy handling, easy molding, gave us a better stability when you applied these graft materials on the defect compared to just particulated bone. And coupled with collagen graft 2, the covering this graft material underneath all of these collagenated bone, right? So all of these collagenated bone covered by collagen graft 2 collagen matrix. It means this collagen graft 2 working as a little bit barrier function, barrier membrane, and also the soft tissue friendly, the faster healing situation, make faster healing situation. And the last one gave us a contour augmentation, right? So labial portion a little bit enlarged of the bone of the volume, not just bone formation. So soft tissue volume enlargement also give us a good advantages, make a final result. So extraction and wait months, and then the after healing soft tissues area and insertion, this implant bright TL diameter 2.0, a very narrow diameter. However, all of these fixtures surrounded by host bone, and also this implant fixture thread engage the cancellous bone. So extremely reduce the stress of bone crest. It means it is very important the recognition and information. When you have implantation, as you know, the stress of bone crest area, it means sometimes resorption of crestal bone or some recession of soft tissues after final restorative delivery, right? However, just only engage to cancellous bone and the feeling free of crestal bone means a better result for a long-term follow-up. Healing 1 week, and the intraoral scan for temporary, and the CAD workup with provisional restoration was delivered to our patient mouse. And the later months, actually 2 or 3 months later, after tissue molding, and all the anterior implantation tissues are stable, and then we're going to do the final restoration with the zirconia final restoration, including the neighbor teeth, zirconia crown. So final impression, always final impression taken by BTS technique in the Dentium, the concept, from the Dentium concept, right? As you know, Dentium concept, intraoral scanner for PMMA temporary provisional, and the BTS for final restoration. Why? BTS is more accurate compared than intraoral scanning the data, especially long-term, long span case, actually the curvature case. Always we're gonna see the more accurate the outcome from this BTS technique. Okay, the CAD and the final restoration with zirconia. So delivered to our patient mouse. Actually, it's a little bit recession because of these implant areas. It's very difficult to have the aesthetic outcome compared to natural neighbor teeth case. However, after the time to time, maybe some of gingivals enlarged the field interdental papilla and a little bit clipping on these cervical areas of final restoration of implant-supported processes. However, not exactly same equal situation in final. So if you want to have a little bit more, the better aesthetic outcome, you need some gingivectomy or gingival contouring on neighbor teeth. Neighbor teeth means number 21. And number 22 also including the number 12. All of the anterior natural teeth should be a gingivectomy or some gingival contouring to make the harmonious gingival, marginal gingival level with implant-supported prosthesis. After 5 months, follow-up confirm CT shown us about very nice, well done, also integration situation, and the marginal bone crest and the crestal areas. Okay, we're going to move to today's surgery. As I mentioned before, today's surgeries will be done on the lower anterior. All of these lower anterior teeth was periodontally compromised case. So already gingival recession and bone recession. So this anterior area, the extrusion and the mobilities, so these are hopeless teeth, so should be extracted. And also in this kind of case, in this sort of case, the immediate implantation will be possible because of the horizontal, the reduced ridge areas. Is possible to have immediate implantation, especially lower anterior area. The upper anterior area is totally different, you know. So the upper anteriors engage to the aesthetics, so we may consider more about the more factor. However, lower anteriors, a little bit easier than upper anterior. However, these lower anteriors always have a narrow ridge, strictly squeezing the narrow ridge. So that is a big problem to solve, to overcome. So after extraction, the irrigation, all the granulation tissues should be removed and checking the socket wall. This socket wall is ordinarily shallow, right? Because of the periodontally compromised case. So already all the alveolar bone was resorbed. So remaining of alveolar bone is so small volume vertically. So socket will be shallow. So checking the socket depths, and at this time point actually the one thing of important factor is the labial socket wall is intact or not. So you have to check labial socket wall intact or not, right? So depending on the intact labial socket or the loss of labial socket, the treatment procedures will be changed. Okay. So he is removing the granulation tissues on the socket. And checking the wall, the labial, the lingual bone wall is intact or not. It is important factor, important step to confirming the treatment plan. We got information about this the socket wall areas already due to the scanning, the CT, convex CT view. However, the after extraction, so we may cross-checking again to confirming the existence of labial wall. So starting the drill. When we have a starting drill, now Dr. Chung using this Fisher bar, high-speed Fisher bar. This high-speed Fisher bar is a good point to initiation. What? First, actually, the exactly starting point, drilling on this socket. Because of this socket surrounded by cortical bone, sometimes the drill, even though the Lindemann drill, they're easy to slippery. However, this high-speed bar is no slipping, no sliding, and we can get exactly the starting point. So after initial drilling and packing the bone graft materials, at this time point, Dr. Chung is using the collagenated bone, the osteogenocollagen, that is introduced before the surgery. So, today's surgery, we will have a 2.0 diameter. So, this Lindemann is a final drill, right? So, first, the Fisher bar was used to make initial point, and then from this initial point, through this initial point, using this Lindemann drill to have osteotomy inside. After that, insert this 2.0, the bright tissue level implant fixture on the 41 and 31 area. Mechanically, actually, 42, 32 area and supported 4-unit implant, supported 4-unit bridge is more physically stable. However, that we have to consider bone quality and socket intact socket. Why? This patient, the elder patient, above 73 years old, over 70, so the intact socket is, choosing the intact socket is better. So 41, 31 inserted and 4 unit bridge will be applied, and that is okay. Cause of lower anterior is almost the straight span and the shorter span, even though the 4 missing teeth area. So this anterior cantilever area and cantilever style, the prosthesis will be acceptable. Okay, after insertion, the checking the torque with the hand ratchet. I think during the ratcheting, I can guess about 35, almost 35 Newton. So that is enough insertion torque. Okay, removing the plastic cap. This plastic cap is the working as a protection cap. Top portion have a screw thread, so the protecting this screw portion, the plastic cap inserted in the package. So after insertion, we may remove this plastic cap, and then we can connect with the scan abutment, okay, through this the screwed area. This one is scan abutment. The plastic is holder, the scan abutment holder. So the plastic cap promote easy inserting, the connecting to implant fixture top portion. And after that, removing this plastic handle, okay, just to put it out. No screwing, just put it out, and that's it. And we can see clear the top portion of this the scan abutment. Actually, this scan abutment working as the scan jig first, and second the healing abutment, and sometimes we can use this scan abutment as a permanent abutment, like as a dual abutment. If you want a longer one, then you can put the scan abutment longer one. So longer one working as a temporary abutment, and also sometimes working as a final abutment, like a dual abutment of the supine and implantium system. So changing the direction, actually the better direction, to slightly remove again, and then to put it again into the socket area or steatomy area, and to make a better direction and depth, and finally connect with the scan abutment again. Okay, very nice, well done. Yeah. The height is good, and the direction is good. Yeah, three-dimensional positioning is good. Okay, and after that, another bone grafting or another grafting using. Okay, now he is using the collagen graft tool. So this collagen graft tool to promote the faster soft tissue healing. Sometimes have some little bit the barrier function. However, the main function is to make the wound healing through the faster epithelialization of the epithelial cell layer. Okay, right, very nice, a very clever method. First one, the remind again. First one, the point checking, the proper point checking using the Fisher bar of the high-speed bar, and then the packing the bone graft material using osteogenocollagen, the easy packing, and the Lindemann drilling for osteotomy, and implant fixture insertion. It's very simple, the step. And this bright system on lower anterior narrow ridge area, the super simple procedure. This bright tissue level is a super simple procedure, and the great invention to optimize this the narrow ridge area. Also, this bright tissue level, the bigger diameter, regular diameter, using on another location like premolar and molar also. So when you have just only 3.0 diameter, the very small for the molar area. However, that is working, even though the 3.0 diameter of bright tissue level is working on the molar area, right? Because of this design. He is making a suture knot. First, the suture was horizontal mattress suture, right? And then interrupt the sutures. And number 42, the socket area, he will make a horizontal mattress suture. Okay. You're pushing again this collagen graft 2. This collagen graft 2, the cover, the top portion of the extraction socket. Under this collagen graft 2, the collagen xenograft, osteogenocollagen was located. Yeah. Actually, there's a suture, the cross suture, right? Yeah. The cross suture was done on this number 42 socket area. No flap displacement anymore, and no primary closure at all. Applied with the open wound concept for using this collagen graft 2. So that is a good benefit, a big favor to using this collagen graft 2. And this suture knot will be final. Okay. Yeah. Yeah. Two implants inserted on the 31, 41 area and bone grafting simultaneously with osteogenocollagen and open wound concept, the healing procedure using collagen graft 2 and the cross suture and horizontal matrix suture, interrupted suture. The simple suturing was done for secure this surgery area. Okay, the surgery was done. Thank you for watching, and we will have a 10-minute break, and also we will have a Q&A session. And before the Q&A, we will see the follow-up of this surgery. Thank you. Thank you for waiting, colleague. Let's see the post-op intraoral view. As you can see, this implant, two implant fixtures, bright tissue level, was very nice installed on the socket number 31 and 42, and also with bone grafting with osteogenocollagen and also collagen graft 2. What about the cone-beam CT view? Very nice, well done insertion on number 41 and 31. So that is why cause of the installation socket. As you know, number 32 and 42 is okay. However, 41, 31 is better than this remaining socket. So that is why choosing the proper socket for the implantation. So very nice, well done insertion on the cancellous bone area. So even though the labial the concavities on this 31, 41 area. And the healing 1 week situation, the faster healing situation was seen. So as I mentioned before, you can remember this collagen graft 2 is the main effect is faster tissue healing, especially faster epithelialization healing, right? The epithelium healing for the epithelial cells migration, the inducing the faster epithelial cell migration. So just only 1 week, all the surgery areas was closed and they healed very well. And after that, intraoral scanning here for temporary PMMA, right? So the same day scanning or the stitch out day scanning, it doesn't matter. For me, actually, the same days, the scanning is a favorite, right? The surgery day, the scanning, and then after that, 1 or 2 weeks later, the stitch out, and then give the PMMA temporary prosthesis to our patient mouth. This is better procedure. Anyway, the CAD situation here, and also the tie base abutment with the PMMA temporary. So we're going to use this tie base as a temporary abutment. So combined with PMMA temporary, and sometimes this palatal wing, upper area, the lingual wing is more the comfortable situation, give us a more comfortable situation. Why? This temporary contact to the neighbor, strong the neighbor teeth, the bonded resin bonding, right? So this extremely reduce the stress of just inserted implant fixture, right? So this wing is important and the clever procedure. Okay, and the hole on the labia doesn't matter cause of the temporary, and insert into the patient mouth with the wing. This wing contact to neighbor teeth with the resin bonding, and okay. So all of these follow-up situations shown us about this the simpler way to make a temporary during the healing stages, and then we can go the final restoration with the zirconia, made by zirconia processes for unit bridge supported to implant fixture. Okay. Okay, let's move to Q&A. Very nice, good question is here. Is a bright TL diameter 2.0 implant appropriate? It means the lower anterior socket area. As you can see, what about the cone-beam CT view? Very restricted, narrow area. So 2.0 implant fixture is the best option, the best choice for this narrow ridge, narrow socket area. Some doctors want to have a little bit bigger diameter with the GBL procedure or some bone grafting procedure. However, lower anterior areas, it is not enough to have wide diameter like 3.0, 3.5. Sometimes 3.0, 3.5 is acceptable with this patient also existed. However, the elder person and normal, the Asian person have a restricted and narrow reach. So just only 2.0, 2.5 picture will be acceptable and available for this socket. If you choose a little bit bigger diameter implant fixture, you may have the complex procedure like a bone grafting, GBR procedure using the barrier membrane. So all of this procedure is not the same matching, the simple, easy, and the faster implantation concept. So nowadays, actually, the simpler bone grafting, simple implantation, and the easy prosthesis, all of this concept is available and prevailed nowadays, right? So 2.0 is appropriate and best choice for this patient, lower anterior. So what is your favorite diameter on lower anterior area? Actually, for the lower anterior area, not exceed 2.5 actually. Previously, until now, if you want to have a smaller diameter, 2.0, 2.5 implant fixtures, it is very the limitation of implant fixture selection. So one piece implant or some another the tricky shape of implant was available. If you want to have the bone level implant, the implant fixtures, the smallest diameter 3.0. In Dentium, 3.0 diameter of the aniline system. Another system have the 3.5. Another company is also supply 3.2, 3.3, about around the 3.0 diameter. That is the limitation, the narrow diameter, the two-piece implant. So this kind of case, if you choose the 3.0 diameter bone level implant fixture, you have to do something more. What? GBR procedure. So the complex cases, make it complex, make it complicated, right? So that is not matching to simple, easy, the faster surgery concept. So for me, actually, I always try to the under 2.5. Sometimes I choose 3.0 if the ridge width is available for 3.0. However, the ordinary case, actually 2.5, 2.0 is acceptable without bone grafting or the simpler bone grafting or just sort of gap filling like today's case, today's surgery, right? So no flap reflection anymore, just a slightly flap reflection is enough to have a bright tissue level 2.0, 2.5 on lower anterior, and just gap filling and suture, and that's it, right? So please make it easier. Please make it simpler. So I strongly recommend you this bright tissue level implant. Bright tissue level implants apply our situation. The supply that gave us a good situation and gave us a good chance to try just the smaller diameter, the safer to make osteotomy site inserted into the socket. Not anymore the higher stress on the crestal bone, right? So that is my answer. So if you want to choose 2.5, 2.0 diameter, you have to choose bright tissue level. Not anymore another bone level. The another bone level, it is impossible to supply this a smaller diameter cause of its nature, right? Internal connection, the limitation of internal connection. However, this bright tissue level have external connection, beveled external connection. That is a strong point, and that is a good reason to make a smaller diameter, make it simpler, and make it easier surgery. Okay, thank you for watching today's surgery and the follow-up session. Okay, we will have next live surgery session July 18th, and Professor Kim will be the surgeon, and we will have a very nice soft tissue surgeries. Okay, thank you. See you later. Bye.